So now that we know the prevalence is high, how do we screen patients? We have to identify patients with high risk for MASLD, like with type 2 diabetes, prediabetes, or obesity with cardiovascular risk factor. This algorithm is recommended by American Diabetes Association. So we have to calculate FIB-4 score, which in the next slide I will say based on what criteria it's calculated. If it's 1.3 or above 1.3, but less than 2.67, it means that patient needs to undergo fibroscan, which is an imaging modality, and it gives us liver stiffness measurement. If the number is 8 kilopascal or above 8 kilopascal, it means that patient is at high risk of cirrhosis, so we have to send them to a hepatologist for further workup. But if liver stiffness measurement is less than 8, it means that patients can be managed by primary care or endocrinologist. We have to optimize lifestyle and treat their comorbidities and repeat FIB-4 score after a year or two. If FIB-4 score is already above 2.67, it means that patient is at high risk of cirrhosis, so we don't need to do fibroscan, we just have to refer them to hepatologist. If FIB-4 score is less than 1.3, it means that patient doesn't have high risk for cirrhosis, there's lower risk, so we can again manage them and optimize their care for type 2 diabetes, obesity, and encourage healthy lifestyle, and repeat FIB-4 score after a year or two. So in UIHC, calculating FIB-4 score is easy because we have to just use a dot phrase, which is created by hepatology and endocrinology department. So FIB-4 score is calculated based on AST, ALT, patient's age, and platelets. And again, it gives us a FIB-4 score. If less than 1.3, then patient is at low risk of cirrhosis. So we know that we just have to repeat it after a year or two, in addition to managing their comorbidities. If it's between 1.3 to 2.67, it's indeterminate. So we have to perform fibroscan. And if the number is already above 2.67, we have to refer them to a pathologist right away. How we do manage them? So lifestyle modification is cornerstone of therapy, meaning healthy diet and exercise. Mediterranean diet is a good choice for healthy diet. Weight loss, 3 to 10%, was shown to reduce steatosis and help in fibrosis regression. Again, we have to manage existing comorbidities like type 2 diabetes, dyslipidemia, hypertension. We have to strongly encourage patients to avoid alcohol and smoking, and bariatric surgery can be considered for some patients who need weight reduction. Pharmacologic treatments. Semaglutide 2.4 milligram weekly is approved by FDA, as well as resmetirom, which is selective thyroid receptor agonist. And American Diabetes Association recommends pioglitazone and even recommends combination therapy with pioglitazone and GLP-1 receptor agonist. So, take-home points. MASLD is the most common chronic liver disease. It needs multidisciplinary management of cardiometabolic risk factors. And early identification of high-risk patient is key because then we can prevent the progression of disease into fibrosis or cirrhosis. Lifestyle modification like healthy diet and exercise plays an important role in managing these patients. And we can initiate FDA-approved therapies if indicated, like semaglutide or resmetirom. And we have to refer some patients to bariatric surgery if they need surgery for weight reduction. These are my references and guidelines, and thank you very much for your attention.